So thank you very much for having me. I'm really thrilled to be here. I enjoyed all of yesterday and this morning as well. And I've enjoyed meeting many of you patients throughout the day yesterday and this morning. So I'm coming to you as the nurse coordinator for the neuroendocrine tumor program at the University of Pennsylvania. Our program's been in existence for about 10 years. So I've heard many, many patient stories, and the tumors are really not rare for me. So just to get through. So in my role there, I'm really a support person for family, for patients and families. I wear many hats, you all probably can say that you're support people for all that you've learned, those of you who've been on your journey for a while. I'll just say at the bottom there for research activities, just to echo what you've heard along the way, I do consent patients who are going for surgery. So that's a big role with my PHIO-para cohort. And everyone is so generous and giving and willing to participate, and we really appreciate all of the tumor samples and those of you who participate as well in the database because we learn a lot from just your experience. So it is a rare tumor that you're dealing with, but as I said, not rare for me. I do see all of the patients who need blocking preoperatively. So we see many more patients, those of the head and neck that maybe aren't secreting, but those who are would be patients that I would see. And I would just say that every patient is unique. Each patient has their own story. You all need individualized care. Care plans, and one size doesn't fit all. So I usually begin by asking patients to tell me their stories so that I know how they'll fit into our program and what I need to do for them. There are many ways that patients come to my attention. You may be referred by one of the doctors in our institution, or you may be referred from outside. You may want a second opinion. You may be a new diagnosis. You may be looking for a clinical research trial. So I need to know where you are along your journey's way so I can help get you plugged into our program. One of the major things that I will help patients do is gather their records. It can be quite a task. Sometimes patients will say, I'll bring my records with me, and then they'll come with a big stack, and the doctor doesn't have time to really go through. There may be a lot of duplicates there, so I will help organize those records. Some of the reports that will be collected are listed there, and I'll talk about a couple of them specifically. So the pathology report is really important for people who've had surgeries or tissue taken. And if you think about what is the pathology report? So it is the pathologists writing in words what they see the tumor looks like. So, you know, pictures speak 1,000 words, and the pathologists have to put that down. So if you look at your pathology report, you'll see a description of the tumor, the color, the size, that type of thing. And then you'll also see what the tumor looks like under the microscope. That will be the microscopic description, and will give the diagnosis for the tumor. So they get specially stained. Maybe there's a PAS score. One thing about PHIO-para pathology reports is that they're not often standardized. So some parts of the country you may see a GAP score come in, and other a PAS score. Some places don't give a PAS score for paragangliomas, so they're not consistent. You may be asked to get your pathology slides for review. What does this mean? It means that a pathologist will make a second opinion regarding your slides to confirm the diagnosis. We may need to do this before you get treatment, or if you're going to be participating in a clinical research study, we may want to verify that we agree that you have a PHIO or para. Laboratory reports, we've talked a lot about that already, but you know, the wrong labs may have been ordered by the doctor who's sending you just because your tumor is rare and they don't know what labs to get. So sometimes we'll see that, or they may be incomplete, like we don't have catecholamines and metanephrines. They may be illegible, as in this report here, where very important, I need to know what the normetanephrines are so we can figure out what type of, how much blocking medicine to give. And are the normetanephrines 1.4 or are they 14? So this patient actually came into the clinic on a very high dose of phenoxybenzamine for Blockade, 20 milligrams 3 times a day, which is a huge dose if your normetanephrines are only 1.4, and the patient was very symptomatic. So it's really important that we have legible reports. We may need labs for a variety of reasons for preparing you for blocking. So if I'm getting a new patient coming into the clinic, I'm kind of a fanatic about getting your labs there so that I can plan ahead and help determine how much blocking medicine you need. So I'll be really interested in getting that information. We may want the labs for a new baseline after you've had surgery. We always wait 4 weeks after a surgical procedure before we recheck the labs because they can still be elevated because catecholamines are stored in your blood platelets. So we don't get the labs until about 4 weeks after you've had surgery. And if you have symptoms that develop, we may also get labs sooner than we normally would just for screening you. Labs should be checked lifelong. That's what we say now for monitoring patients. One thing I've noticed, a lot of the folks in the audience seem to have genetic disorders and are well plugged in and have a regular screening protocol. But I worry about those folks who had a resection and, you know, maybe they're cured, but we know that things can come back years later, and those people sort of maybe don't come back to the clinic and drop off, and they are the people that I need to be calling and saying, you know, where are you? Are you okay? Have you gotten your labs done? We like to keep a running table of labs so that we can see what they look like over time. It's very helpful not just look at one lab result as it comes in. So I like to point out that there are different assays for the tests, so you can't just look at numbers and think that you're looking at apples and apples. So there, where the normetanephrines are 1.3 with one of the assays, and the next one test done was a different assay where 178, they have different reference ranges, and you have to take that into consideration when you're looking at the labs. We may be looking at for a new baseline, like here after surgery, so the numbers, biochemistries were elevated before surgery. Now what do they look like post-op? We may be looking after treatment. Here this patient had a Zedra, and what do the trends look like after that? And then our patient called and said that her blood pressure was out of control, so we got labs sooner than we normally would, and you can see here that her normetanephrines took a dramatic increase, and we need to get going with a new treatment for her. Again, lifelong follow-up is necessary. Alpha blockade, this is a big area where I work with patients, and Dr. Dillon did show in his talk yesterday a little example of what we mean by that, but here this patient was headed for a stenting procedure because he had a blockage in his biliary duct, and the gastro doctor who was going to do this procedure didn't take into consideration that the patient has a FeO. And I said, whoa, Nellie, we have to make sure that his alpha blockade is on board before he has the procedure done. So he was on alpha blockade, just taking phenoxybenzamine once a day, which really isn't enough for levels as high as this of the catecholamines in his blood. So we had to increase his blockade before he had the procedure. And then the goal of what we're trying to do there is to block the uptake of the catecholamines by the blood vessels with the medication that we're using for the alpha blockade so that we can keep the blood pressure controlled during the procedure. So his blood pressure did go up when the anesthesia was initiated and then fell back down and was well controlled throughout the procedure. And here again, you want to think about whether or not you should be wearing medical alert ID. If you have a mildly secreting head and neck tumor, maybe you're just secreting dopamine, you still may need some blockade. Even for dental procedures, for our patients, you know, it's stressful just going to the dentist, but then if you're going to have a procedure done, you know, you may need some blockade or intensification of the medication that you're taking, so you should be speaking to your doctor about that. Imaging reports are another important component in gathering records together for patients. Again, they need to be legible. We need the reports from anatomical and functional. Again, a variety of uses. Are we using it to locate tumors for new diagnosis or surveillance? We can get the pace of your disease to see if you're stable over time or if your disease is more aggressive and we need to give you treatment. And it may, we may be getting it for a new baseline to see what things look like after you've had treatment or a surgery. And then also for the functional imaging to determine if a treatment option is a possibility for you. So if you have an MIBG scan that's positive, then you would be a candidate for a Zedra. Or if you had a gallium-68 scan that was positive, you'd be a candidate for possibly Lutathera trial. And if that comes available in the United States. We need, if you have imaging done at an outside location or you're coming to us as a new patient, we need to have your imaging on CD. I mean, we can't take care of you simply by a report that we read. We need to see the imaging on CD. It needs to be in the proper format. You need to come with CDs in DICOM format. Oftentimes we get screen captures. You may not be aware of that, but just snaps of different aspects of the study that you had done at other locations. So we need the full study in DICOM format. Occasionally we'll get a corrupted disc, and if we don't have this information when you come to see us, then it delays your care. This helps to show some concepts that I think people have a little difficulty understanding. One is physiologic uptake. Sometimes patients will be upset when they read their report and they see that it says they have physiologic uptake in different locations, organs, and things, and think that they have tumors there, and that's not the case. The physiologic uptake is where the radio tracer is going through the tissues in the body normally, and it's just the background. On the MIBG scan and the Octria scan there, you see one tumor circled there in red, and then with the FDG PET, it's picking up more tumors, and then with the gallium dotatate, there are a lot more tumors picked up. Now, all of these scans were done around the same time, and this patient actually has a head and neck tumor as well that is picked up here. On the gallium scan. And so there's this concept of a new baseline. So imaging going forward, we'll use the gallium dotatate for this patient. So all of the tumors may have been there all along, but we just couldn't see them. Now we have better imaging techniques. One thing, if you try to give us a CD, I probably should have had this in the other order, a CD copy that you copied yourself, and we try to upload it, we will get a message here saying it's not in standard format, because you may not be aware that when you try to copy it, the copy is not made in DICOM format. So please give us CD copies that are made from the facility where you had the scan done. We encourage patients to sign up for record sharing programs. At University of Pennsylvania, our program is called Care Everywhere, so this particular individual, we would be able to share records with those facilities over there on the left. And one important thing to know is that not everything can be accessed through Care Everywhere. So if you had a scan done at an outside like imaging facility, and you took the report to your doctor and the CD to your doctor, we would not be able to see that report. It would be scanned in. And if you also had labs done outside, they would be scanned in and we wouldn't have access to them. So just be aware of that. And we wouldn't have access to the actual pictures of the imaging, just the reports. But this is very helpful for us to have for patients. We also suggest that patients sign up for patient portals if they have them at your facility, because there are a lot of benefits to participating. They're not for emergencies, to send emergent messages. We did have a patient who had a serious fall while they were away on vacation, and they were signed up for the portal. And when their family called me and said that their doctors were looking for their medical records, I said, well, you can access them on MyPen Medicine. They said they didn't have the password for their loved one. So you might want to think about if you need to get your records and you're not able to get them, is there a way that you've provided for others so that they can gain access to this information? I do a lot of communicating with the multidisciplinary team at our institution. We have a tumor board where experts gather together, especially if we need to come up with a treatment plan for a patient. Collectively, we'll customize a plan for each patient. Then we have to get that plan documented in the chart so everybody's aware, and then communicate back to the patient. So this little cartoon has also been shown throughout the week. It really takes a multidisciplinary team, a group of caregivers to provide proper care for patients with these kind of tumors. I mean, you might have a head and neck tumor and an abdominal tumor. You may have a genetic disorder. You may not. You may have metastatic disease in your lung. You may have had damage to your heart or have had a stroke. So it really takes a large group of doctors who know about how to take care of patients with these rare tumors. I would also echo Dr. Fishbein's suggestion that letters be sent to all of your caregivers so that they learn about the tumors. Sometimes we'll have a patient come and say, I don't want so-and-so to get my letter, maybe because they didn't come up with your diagnosis so quickly. But it's a great way for us to educate other doctors and the community about the disease and how we care for it by sending letters to everyone who cares for you. And I will say that medical genetics is the key here. All of our patients get referred to medical genetics, and that's a difference in the other tumors, neuroendocrine tumors that I take care of, patients with tumors in other locations, and they don't have the genetic predispositions as FIOs and paras do. One thing that we found about is that patients can gain weight after surgery. So here, pre-op, this patient weighed 138, and then after surgery, about a year out, they had gained a few pounds. So we did analyze our data and find that people can gain around 10 pounds after they have surgery. So we started warning people of this or letting them know ahead of time so that they could watch. This particular patient said, why didn't you tell me that I could gain weight? And then another thing that we looked at in our clinic is the variability of blood pressure for catecholamine secreting tumors before and after resection. I'll often share this with patients who are being blocked. We'll have them come in, bring their home blood pressure monitor so that we can validate that it's reading properly. And then I'll share with them that we do expect that your blood pressure is going to be variable so that they won't be really upset if they take the reading and one time it's 120 over 80 and the next time it's 150 over 90. So we do expect that blood pressure will be variable while high catecholamines are high in the bloodstream. And then this is the same person after surgery. You can see blood pressure is much better controlled. Here's another example of a patient before and after surgery. This particular young patient had had 2 heart attacks before her tumor was found rather incidentally. And you can see those spikes in blood pressure. She was actually studying for final exams. So I like to just point out that stress can cause these elevations in blood pressure. Very interesting, she kept a diary and we were able to go back and see what she was doing when she had these severe spikes. And post-operatively, her blood pressure is beautifully controlled. Just a word about misinformation out there on the web. This is a rather reputable site, and you can see here, there in red, adrenal biopsy that can show a FeO, and we know that biopsies are definitely not something that we would recommend that people have, especially if they haven't been blocked. And then what do patients have to say? What's important to patients? So there was a recent survey that patients filled out from 12 countries around the world with neuroendocrine tumors. I'm not positive if FeOs and paras were included in this group of neuroendocrine tumors, but there was an other category, so I think it's fair to say that there may have been some FeOs and paras, but they want better access to NET-specific medical teams, better coordination to care for patients with NETs, and more information about NETs and NET-specific treatments. So those were some of the things that they thought were important. And I think that probably you all would echo those as well. So just some takeaways. I think for me, every patient is unique and lifelong follow-up is a must. So, thank you.
Hi, good morning.
Hi.
My family has also been involved with another organization called Chordoma, and that organization has a very well-run, patient-driven assistance program where you match kind of one patient with another patient in a program, and they have received training on kind of how to help with the transitions and issues that happen with patients. Do you guys have something like that?
No, but that sounds like a great idea.
I am.
If a patient is suspected of having a pheochromocytoma and they're already on alpha blockers and additional testing in plasma is recommended or urinary, how does it affect the results if they're already on an alpha blocker, and to take them off would result in lethal high blood pressure?
We wouldn't take patients off of an alpha blocker. We would just get the test knowing that they were on it and interpret, knowing that. But, a lot of these patients, we know they have, metastatic disease, so we just, measure the trends over time, and they can be, stable for many, many years for, very long time with elevated numbers but stable disease. So we don't take patients off.